Hello, everyone, and welcome to the April issue of DermSurgery Digest. I am Michael Renzi with Lexington Clinic Dermatology, co-host of the podcast. This month, we are excited to premiere our updated format, which will separate the cosmetic portion of the Dermatologic Surgery Journal into two 30-minute episodes. This episode, which we are calling Rapid Clinical Pearls, will briefly cover the clinical application of the data from each article not covered in our Spotlight episode. Our goal with this format change is to make the content more digestible with a focus on clinical application and enhancing patient care. Our feature editors for April are Kyle Lauck with Cooper Hospital, Rowan University, and Catherine DiGiorgio with CMD Dermatology, Laser, and Aesthetics. Thank you for listening. We hope you enjoy this new format, and as always, have a happy surgery day.
Hi there. Welcome to this month's DermSurgery Digest Rapid Pearls episode. My name's Kyle Lauck. I'm the current most fellow at Cooper Hospital, Rowan University. And this month's featured expert is Dr. Catherine DiGiorgio. Dr. DiGiorgio, would you mind introducing yourself to the audience?
Sure. I am Catherine DiGiorgio. I own my own private practice in Boston. I trained in dermatology down in New Orleans at LSU, and I completed a 2-year laser and cosmetic fellowship at Mass General Hospital, Harvard Medical School, and the Wellman Center for Photomedicine.
Perfect. I think you are the ideal candidate to help glean some insight from some of these articles today. So this episode features quick article summaries and Dr. DiGiorgio's rapid pearls from the articles published in the April 2026 issue of Dermatologic Surgery related to cosmetic and general dermatology. All right, we're going to get started with this first one. So this is Advances in Laser Treatments for Seborrheic Keratosis, a scoping review of efficacy, safety, and patient outcomes by Thomas Surratt and senior author Taylor Gray. Seborrheic keratoses are extremely common, benign epidermal tumors affecting 80 million individuals in the U.S. They can cause significant cosmetic concern and discomfort, particularly when numerous are located in visible areas. Traditional treatments like cryo and curettage are effective but can lead to pigmentary changes and scarring, especially in skin of color. This study was a scoping review using PRISMA guidelines to analyze 22 studies, which covered around 1,500 patients, evaluating laser-based treatments for SKs. Overall, lasers including CO2 erbium YAG, diode, and Indy YAG, as well as picosecond devices demonstrated high clearance rates, with many studies reporting single-session success and low recurrence. Patient satisfaction was consistently high, approaching 90% or greater, and cosmetic outcomes were superior to traditional therapies. Adverse events such as erythema, pain, and pigmentary changes were generally mild and transient. However, the data are limited by small study sizes, heterogeneity in laser parameters, and a notable lack of representation of darker Fitzpatrick types. Final takeaway that laser therapy is an effective and cosmetically favorable option for SKs, but standardized protocols and more inclusive, high-quality studies are needed before it can fully replace traditional approaches. Dr. DiGiorgio, I'm curious what you thought about this article.
So this is a review of all of the laser treatments available for seborrheic keratoses, and I think it depends on the type of seborrheic keratosis, the clinical appearance, as well as the patient's skin type and the location on the body. I certainly don't think that laser therapy can replace the good old-fashioned ways of doing things. And in darker Fitzpatrick skin types, I still default to curettage. And when appropriate in lighter Fitzpatrick skin types, I perform liquid nitrogen, and of course curettage can be done as well. I think the macular seborrheic keratoses on the arms in particular can be a little bit more difficult to manage, and that Q-switch or picosecond lasers could come into play, but it's just you don't have to have a laser to treat seborrheic keratoses, which is great. And if a dermatologist has one, they can utilize them safely depending on the patient's skin type and the location.
Perfect. All right, so this is laser therapy for lichen planus pigmentosis and erythema dyschromic persistens, a systematic review by Noor Tarafdar and Xiaoxing Liu. So LPP and EP and EDS are challenging pigmentary disorders that are disproportionately affect patients with darker phenotypes, darker skin phototypes, and are often grouped under acquired dermal macular hyperpigmentation. Standard therapies like topical steroids, tacrolimus, and systemic agents often provide limited benefit, creating interest in laser-based approaches. This was a systematic review using PRISMA guidelines to evaluate published data on laser treatment for LPP and EDP, with attention to efficacy, laser parameters, and safety. In total, the authors included 15 studies comprising 56 patients total. Most of them were women with a mean follow-up time of 7 months. The most commonly studied modality was Q-switched 1064 nanometer, 1065, sorry, Nd:YAG laser. So this showed near complete clearance in about 30% of patients, partial improvement with the majority. Fractional and picosecond lasers also showed promise, particularly for LPP. EDP appeared more treatment resistant overall. Adverse events were generally limited, did include transient erythema, PIH, and in one case, Kepner-Eyes vitiligo. Main takeaways are that laser therapy may offer meaningful improvement for LPP, to a lesser extent for EDP and skin of color, but evidence remains limited by small sample sizes, heterogeneous protocols, and a lack of long-term data. So, Dr. DiGiorgio, I feel like this article provided some nice takeaways, especially for this disease that can affect so many skin of color patients. I think that can be really difficult. I'm wondering what your takeaway was from this article.
Again, it's kind of a review of many different articles. I think it's difficult to determine the efficacy or inefficacy without having controls and a biopsy prior to the diagnosis for some of the cases. So that's just an important takeaway. With a literature review, it's really hard to have that, throughout all of the articles. These two conditions are very difficult to treat. And so it would be great if there could be kind of a controlled study for these patients, so that it's very frustrating for both the patients and the dermatologist, because it tends not to go away with the many therapies that we have.
Yeah, very frustrating disease, and maybe this could be a pilot for some future controlled studies. Okay, next article. All right. So this is characterization of effects of dermal tattoo machine delivery versus conventional topical therapy of croton oil and Hetter's phenol croton oil formula by Soha Gagnon and senior author Carlos Wambier. All right, so phenol croton oil formulations are a cornerstone of deep chemical peeling, traditionally applied topically to induce controlled epidermal and dermal injury. The study explores an alternative direct dermal delivery using a tattoo machine to potentially enhance depth and efficacy. This was an in vivo porcine experimental study comparing tattoo-assisted dermal delivery versus standard topical application of croton oil and Hetter's phenol croton oil formula. Histologic outcomes were assessed at 24 hours, 7 days, and 21 days. The results showed that tattoo delivery produced deeper dermal injury with early hemorrhage from needle penetration and more robust neocollagenesis, particularly with pure croton oil. By 21 days, tattooed croton oil demonstrated increased epidermal thickening and type 3 collagen deposition compared to topical application. In contrast, topical croton oil alone produced minimal dermal injury. Importantly, no scarring was observed, but the tattoo technique consistently created fully ablative patterns. So the takeaway here, it seems, tattoo-assisted delivery may represent a novel method to enhance dermal penetration and collagen remodeling, but safety concerns, including potential toxicity and the carcinogenic risk of croton oil, do remain significant limitations. Of note, Hal Brody, in a commentary on this article, thought that this was a thoughtful and thorough study which could represent a pilot paper for future endeavors using this technique for various header or TCA peels. So Dr. DiGiorgio thought this was a super interesting, novel way of delivering these peels. I'm curious what you thought about it.
Yeah, I thought it was a very interesting way to deliver the peels, and also it seemed that the those delivered with the tattoo had a faster healing process initially, based on the eschar at the various days post treatment. So I think that's an interesting point as well. I wonder about if there was any systemic absorption or any concerns for that, given the depth of delivery of the chemicals. But I think it's an interesting start to a potential in-human pilot.
Yeah, I think the safety concerns are definitely legitimate, and just something that needs to we can work out. But it's really interesting. I think it's a novel approach. So next. effects of 24-hour delayed implantation on graft survival, pilot study by Don Queen and Mark Abram. Follicular unit extraction traditionally relies upon immediate implantation to maximize graft survival, but delayed implantation could offer meaningful flexibility in hair transplant workflows. However, data on how timing impacts graft viability remains limited and somewhat conflicting. This study was a pilot clinical study using split scalp design in 3 male patients undergoing FUE. Each patient received both same-day implantation and 24-hour delayed implantation with grafts stored at 4 degrees Celsius in a hypothermosol concoction. Outcomes were assessed at 6 and 9 months using photography and trachoscopic analysis. The results showed comparable regrowth between groups with no statistically significant difference in follicular unit density at about 19 follicular units per square centimeter in the immediate group versus 18.3 in the delayed. Hair caliber and terminal to vellus ratios were also similar, suggesting preserved graft viability despite the delay. So it seems 24-hour delayed implantation under optimized cold storage conditions could be non-inferior to immediate placement, potentially allowing for staged procedures and improved surgical flexibility, but larger studies are needed. So I thought that this article presents a potentially interesting avenue to kind of change the workflow for these follicular unit extractions. But I'm curious what you thought about it.
I think it's a great pilot study. You know, they have a good long-term follow-up at 9 months for the patients, really able to evaluate the outcome differences, which they showed no difference, basically, and statistically significant difference. And I hope to see this group perform a larger study to confirm their findings, and whether or not their, their holding solution, and their methods of preservation are the key to this versus the studies have been done previously, which were varied in results. Some had no difference, some was a difference. So
yeah, it'd be very interesting to see the longer studies. Okay, next article. High frequency electrosurgery for severe rhinophyma. So rhinophyma is a progressive skin condition marked by sebaceous gland hypertrophy and connective tissue overgrowth, often leading to significant cosmetic deformity and even functional impairment. While multiple treatment modalities exist, including laser, scalpel excision, and dermabrasion, there's an ongoing interest in accessible, cost-effective approaches. This is a small case series of 5 patients with severe rhinophyma treated with high-frequency electrosurgery in cutting coag mode, using a layer-by-layer decortication technique down to the reticular dermis, preserving the sebaceous structures. The results showed excellent to moderate cosmetic outcomes, with physicians rating 60% of cases as excellent and 40% as moderate. All patients reported excellent satisfaction. Reepithelialization occurred within 10 to 14 days with transient erythema, resolving over several weeks. Complications were minimal, no infections or significant bleeding, only mild scarring in a few cases and no recurrences. So it seems high-frequency electrosurgery appears to be an effective, single-session, and cost-efficient option for severe rhinophyma, offering strong cosmetic outcomes and a favorable safety profile. So, I think this article demonstrates an effective way at dealing with rhinophyma. I'm curious what you thought about it and kind of what your takeaway is.
yeah, I think it demonstrates, something that we kind of already knew, but reminds us that we don't need to have laser and energy-based devices to perform these treatments and improve outcomes for patients. So it's a great option for dermatologists that may not have a laser and energy-based device and wants to help out their patient with rhinophyma.
Exactly. Yeah. All right. Last one. This is assessing UV rejection in window tints, a comparative study of professional and e-commerce products. Primary author Nada Hentati and senior author Brian Carroll. Next, so ultraviolet exposure while driving is a well-documented contributor to left-sided skin cancers, yet window tints remain an underutilized form of photoprotection. With no standardized rating system similar to SPF, patients and clinicians often struggle to identify effective products, especially among widely available e-commerce options. This study is a comparative experimental study evaluating 31 window tints using 21 professional-grade products and 10 best-selling e-commerce options using a solar stimulator and radiometer. The authors measured UVA and UVB transmission across multiple trials. Results demonstrated professional-grade tints consistently outperformed e-commerce products, with the average UVA rejection around 99.4% and UVB at 99.9%. In contrast to the e-commerce tints, they demonstrated significant variability, with immune UVA rejection closer to 94%, some products performing as low as 68 to 70%. 70% of e-commerce tents failed to meet their advertised 99% UV claims. The takeaway, not all window tints are created equal, and professional grade products seemed to offer more reliable UV protection. Dr. DiGiorgio, as we round this out, I'm curious what you thought about this article, what you think about these tints and the market that exists for them.
Yeah, so I think that, professional options are always going to be superior, and Amazon products kind of do whatever they want. As we know from several counterfeit topicals that are sold on Amazon, I think that it's our job to counsel our patients on making sure that the products that they're using, whether it's a UV filter or a topical, come from an authentic professional source. And there should be a standardization or at least a truth in advertising for these e-commerce, the companies that sell through e-commerce. If they're going to put a label on it claiming a certain level of protection, there should be some level that's required in order to put that label on, because it's misleading to the consumer, which is really, it's unfortunate, and that's who's affected here.
Yeah.
So good article.
And with that, I think we round out this month's Rapid Pearls episode. Thank you to Dr. DiGiorgio for coming on and providing all these wonderful insights.
Thank you for having me, Kyle. It's been a pleasure, and I look forward to seeing you soon.
Thank you for listening to DermSurgery Digest, the official podcast of the Dermatologic Surgery Journal. To access these featured articles, author videos, and much more, visit journals.lww.com/dermatologic surgery. To learn more about the American Society for Dermatologic Surgery, visit asds.net.